looks like my backyard right now with those colors.
Yeah, no, it does. Yeah, for sure.
Okay, we're beginning the meeting now. We're going to let everybody populate here and take a look and see who's joining. Make sure all of our participants can get in. Julie or Amy, can you check on the participants while I'm doing a screen share? It's kind of hard to see both. They're all filtering in. Okay, and we are streaming on Facebook. I'm going to kind of get started with some, I heard 11 a.m. on Facebook. I meant 12. My brain is off, but I'll edit that later. So good morning, everybody. It's Lisa Salberg, and I'm joining you again in part of our Bighearted Warriors tour. And this morning, we're going to be hearing from our team down at Cleveland Clinic Weston, which is in Florida, for those who don't know where Weston is. And we're going to get started here in just a few moments. I'm just going to give everybody an opportunity to populate and do some housekeeping. This is a forward-facing webinar. There's a question and answer box at the bottom of your Zoom directory on the way bottom of the screen, where you can ask questions throughout the event. These questions may be answered in real time by any of our panelists, or we may save them until the end so that the entire audience can hear them. We ask that you keep your questions general in nature and not look for webinar-based medical consults. That's not wise. So we'll answer general questions, and we will try to address the questions as you need them answered. But in some cases, we may say it's, we're going to have to ask you to ask your individual healthcare provider or set up a personal consult after the meeting. At the conclusion of the webinar, we are going to either, depending upon how many people join us and how the flow of the day goes, we will either stop streaming live to Facebook and let you verbally ask questions by unmuting your microphones. Or if we have a larger crowd and it's going to get a little more busy than that, we're going to go to a meeting room. Meeting rooms are not recorded. And when we tell you you're not being recorded anymore, you're not being recorded anymore. We don't want something that you ask about to be permanently living on social media or on our website if you don't want that information disclosed. So the webinar will use a Q&A box while we are live streaming and while we are recording. And Julie or somebody, could you make sure that we are actually recording? Hold on one second, stop live stream.
It looks like it's
We are
recording.
recording, okay. Technical stuff we just need to make sure is all getting done here. Okay, so we don't want to record anything, so we will let you know very clearly when we've ended recording. And even after we've ended recording, we're asking that you don't ask very, very specific questions about your medical care or ask for specific medical guidance, because that's not what we're here for. We're here to provide education, support, and advocacy. And we have some great speakers for you today who are going to dig into some really interesting topics on HCM. Before we begin in earnest, I'm going to launch a poll, and I'm going to ask you all to participate in this poll through the first sessions. And at the conclusion of the first session, we will then go over the poll results, and that will give us an opportunity to know who's joining us today. So we'll leave that poll open for a little while. You can all jump onto that poll. If you have not updated your Zoom browser, you might find yourself not able to do the poll. I can't help you with that at this moment. So I want to take an opportunity to introduce two of my staff members who are here with us today. Amy Mann. Amy can give a little wave. Amy is our meeting coordinator, and she's coming to us from Connecticut today. And Julie Russo is our volunteer coordinator, who is coming to us from Bethlehem, Pennsylvania. I am at my home in Rockaway, New Jersey. So we have the tri-state area pretty well covered right now. I am going to hand over control to, I'm going to do a stop share here so we can get off to the next. I'm going to hand it over to Dr. Craig Asher, the director of the HCM program at Cleveland Clinic Weston, to kind of give an intro and kick us off today. And Craig, I hand it off to you.
Okay, good afternoon, everyone. Give me a second here, and I'm going to try to share my screen. Can you see my screen?
We can.
You can, okay. Okay, so this is where we are, the Cleveland Clinic in Weston, Florida. We're about 25 minutes west of Fort Lauderdale. And we became a center of excellence just a few years ago, 2018. We're one of the 2 centers of excellence in Florida. Really honored to be part of the HCMA. This is our team, our core team of cardiologists, other than myself, Dr. Lopez, who you'll hear from today. Dr. Lopez is a young star in our department, and a multimodality trained cardiologist. That means that he interprets echo and nuclear scans, CT scans, MRI scans. Dr. John Navarro. John is director of the Echo Lab and a very experienced clinician and researcher. And then we have several other EP doctors, structural doctors, heart failure transplant doctors that are also experienced with hypertrophic cardiomyopathy. And then important to note that we do have a close bond with our colleagues in Ohio, Dr. Desai, Dr. Harry Lever, who I'll speak a little bit more about later, who's my mentor. We do have a relationship with the genetic counselors in Cleveland to help us out with some virtual visits. And of course, critical to the success of our program is that we're able to share Dr. Nicholas Madeira, who you'll also hear from later this afternoon, the cardiac surgeon that does myectomies, probably one of the most experienced, most high volume cardiac surgeons for hypertrophic cardiomyopathy in the world. And he's been coming to our site about twice a year. Unfortunately, this year with COVID, has not been able to travel. Oops, I think I lost, let's see, okay. So to get an appointment here in Weston, it's as easy as calling this number. We do both virtual visits and in-person visits. We've been doing a lot of virtual visits of late. It's a nice way to get to know people and to structure their visits when they come to Weston. So this is the agenda for today. Lisa will talk about the HCMA, and I'm going to give a bit of an overview of hypertrophic cardiomyopathy. It'll be tailored a bit towards new patients to our clinic. Dr. Lopez is going to talk about the different tests that we do and why we do them. And then Dr. Smadira will talk about surgical myectomy and I expect show us some really amazing pictures. And then we'll have the Q&A panel discussion at the end. So Lisa, I think you're up first. I guess Lisa needs no introduction to this audience. I'll just say on behalf of the physicians that we're really in awe of your dedication, your energy, and your life story. And so we think of ourselves as supporting cast that are on your team, and just look forward to helping.
Well, that's very sweet. But I think I'm the supporting cast. You guys are the main characters. And had we been able to do this in non-COVID times, there was a theme that I was trying to get together. We haven't been able to play it out exactly how I envisioned it. But if you notice, the name of our tour is the HCMA Presents. the Bighearted Warrior Tour, Bighearted Warriors Unite. It was meant to be like an 80s rock band tour theme. There was going to be a t-shirt. There were going to be concert dates on the back, because to me, you guys are the rock stars. And we wanted to kind of put you up there and create this environment. We had music from the 80s, all heart related stuff. It was going to be a lot of fun. I was going to have Rubik's Cubes made with HCMA logos on them. Instead, I sit here on a Saturday morning from my computer room in New Jersey, wishing to get on an airplane again someday and see human beings in person. And hopefully we'll get to that point someday. So this was supposed to be an in-person tour. It has been turned into yet another Zoom meeting, but we're hoping we can keep you engaged and educated and get you a little bit more involved in the community as we move forward. And I think by the end of this tour, everybody will hear my talks on different meeting tours, and you'll get a little something different every time, because if you want to go back and hear it, we've done it a few times already, and I want to give the time to our physician hosts. So I'm going to just start with an overview of the actual event. Let me just move some stuff around on my screen here. And we have our agenda for today. I'm going to kind of flip through my slides. I'm going to show you all my slides, but I'm going to talk pretty quickly on them so that we don't get into redundancy, because we are going to talk a little bit about mimickers today. What is HCM? What is an HCM? And what the HCMA is actually working on in terms of new projects and initiatives. So we've got that. I want to take a moment to thank our sponsors, Myocardia, Cytokinetics, and Vitae and Boston Scientific. They were sponsors of the tour before it went virtual, and they've been great partners in terms of us having to reimagine and revision how we're going to get our community together and how we're going to educate people about HCM. And we really appreciate the sponsorship. As many of you know, Myocardia announced about 2 weeks ago that it was in talks or has an offer to be purchased by Bristol Myers Squibb. We have been assured that our relationship will be maintained through this new company, but we're waiting to establish some better relationships there, or new relationships, I should say. So I don't think the name Myocardia is going to go anywhere anytime soon, and we wish them luck in their endeavor. Okay, so I have to give a full disclosure. I did not give this in my last Cleveland Clinic disclosure, but I think I should give it as a disclosure. In 2006, when my father was in need of surgery, at this point not a myectomy, but a mitral valve replacement, he chose the Cleveland Clinic, and Nick Madeira operated on my father. So I guess that kind of says something about my level of trust for Nick, because I let him touch my daddy, and he did a great job and gave my dad a number of years of continued good health. So for that, I'm always appreciative, but I have to bring it up because, you know, got a soft spot there. So let's talk about what HCM is and isn't. And many of you who are viewing have been told at some point in time that your symptoms might have a different definition. Some of us call that misdiagnosis. Some of us call that misinterpretation. I call it just a good old mistake, and we got to get the right answer. So many of you have been told you have asthma, specifically athletically induced asthma, mitral valve prolapse, panic or anxiety attacks, depression, and most of you, over 50%, have been told that you have had an innocent murmur, when in fact you actually had hypertrophic cardiomyopathy. We are hoping that working with our Center of Excellence partners, artificial intelligence, electronic medical records, that we are going to be able to aid in the discovery of those with HCM or at risk for HCM by using technology to assist. So if you have all of these mimickers on top of a family history of heart disease, pacemaker, defibrillator, sudden death, open heart surgery, transplant, that this is going to start raising the awareness to the general physicians out there, the family practice docs, that hypertrophic cardiomyopathy is something that they want to start looking for and order the proper tests and get you the proper assessment to get you into proper care in a more timely manner. Some of our members have defied proper definition. For on the extreme, we have 150 years. On average, it's about 10 years of complaining about symptoms and not being properly identified for a decade. So we want to get in front of that, and we want to get you into early identification. So we're hoping that this model that we're working with a number of our programs on will assist, and that we can create models within electronic medical record systems throughout the world that'll help to identify those who are at risk for heart disease. Okay, there we go. So how many people really have HCM? Well, you've probably heard the 1 in 500 number. It's been out in the literature for about 20 years now. So the 1 in 500 comes from echo data, and that echo data was collected in a in the United States out of a program out of Chicago where like 6,000 people just randomly got echoes, and Barry Marion had reviewed them and found that 1 in 500 met the definition of the clinical diagnosis of HCM. So that study was replicated in a number of different populations all over the world, to indigenous Americans, to people in China, to people in India. In all these populations, we can see 1 in 500 on echo. But then MRI stepped in and we realized we were missing some. And additionally, we were able to get more knowledge out of genetic testing, and we found that we were missing some. So when you look at genetics, MRI, and echo, we're probably closer to the 1 in 200 number. This number is still, where am I? There we go. This number is still a little out there because we haven't got it defined really well yet. However, it looks like it's going to be closer to that 1 in 2 than 1 in 500, which means there are somewhere between 750,000 and 1 million Americans with undiagnosed HCM right now. Our problem and our challenge and our call to action, if you will, is there's really like only 125,000 of us with HCM currently in care for HCM, which means that 80% of our fellow big-hearted folks have yet to be identified. And we're going to be working on mechanisms to help find them. So we're going to talk a little bit about that. I'm not going to spend a lot of time on this slide today, only that we are dealing with something that we know and some things that we don't know still. We are all learning together. And everything that we're going to talk to you about today and through this entire tour is what we know today. And we're going to talk about some hopes for the futures as well. But we know that the sarcomere mutations are responsible for about 50% of those who get genetic testing. You can look at some data, it'll say 40% have a known mutation. Some other data will show higher numbers, some a little bit lower, but 40 to 50% we know have sarcomeric mutations. Then there's this group of people who have no gene mutation currently identified, and we don't really know what is causing the HCM in those individuals. And then we have individuals who have non-sarcomeric mutations, and I only labeled a few here. I should update this slide with a few more. There's something called AMP kinase. It looks like HCM, it acts differently. Fabry's disease affects other organs and the heart, but when it affects the heart, it looks like HCM, but it's not, and it has its own therapy. LAMP2 or Danon's disease looks like HCM, but it is a multifaceted disease state that can be very, very deadly in young males and differently affect younger and middle-aged females. It has its own therapy that we're working on right now through another clinical trial. And there's also confusion with amyloidosis and sarcoidosis being called HCM because the clinical features look alike. So it's really important. The first thing you do when you get to an HCM center of excellence is confirm that you actually have HCM and not one of the mimickers. If you have one of the mimickers, we go down that pathway and we can treat you there. If you have HCM, that's what we're going to be talking about for the rest of today. So there's pathways in HCM, and some of you will fall into one of these buckets or 2 of these buckets or 3 of these buckets, or maybe even 4. I had fallen in at different points in time to 3 different buckets here. I'm not going to spend a great deal of time talking about this because I know Dr. Lopez has a very similar slide, and I'm going to let him dive into that one a little bit more. But suffice to say, we all have to figure out which pathway we belong in, and why high volume center care matters so much is because of this slide. The average cardiologist in the United States sees about 2,000 patients in their practice. Statistically speaking, maybe they'll see 10 people with HCM. But what are the chances that they've seen multiple people that fall into the same buckets and the same categories as those other people that they've seen? So instead of having a breadth of knowledge that expands over hundreds and thousands of patients, they're kind of learning off of onesie twosies. And that doesn't serve the patient population very well at all. We want to make sure that patients have the access to the highest volume care so that they can get the best results. We're really looking for good outcomes here. And that's what the Center of Excellence modeling has been all about. And when we created the Center of Excellence model, we kind of did it by mistake, in all honesty. And Cleveland was one of our first because we had a good relationship with them. We knew patients would go there and get really good quality care. This is like in the mid-90s. And we knew that they could get a good surgery there. I believe when I started working with Harry Lever, Nick and Bruce Lytle. That's the name. I couldn't think of his name the other day. Bruce was training Nick, I believe, in how to do a myectomy, and they were doing about 25 a year. And I'm like, wow, that's great. That's an awesome high number. Now they do about 225 a year. And they look back at those 25 a year numbers and think, boy, it was a lot easier back then. I actually had weekends. But that's one of the core elements that we saw at the HCMA that was really beneficial to the patient population, having a high volume surgeon who knew what they were doing. Mayo Clinic had a similar program, and those were the two. And we looked at all of the things that they were doing, and also then understood that not everybody could get on a plane and get there. So we needed to make sure that people in America had more options. So this is our map as of today. I know Craig showed you a map a little earlier. It's a little bit different. As of October, we have 41 centers of excellence. 2 of them are waiting a formal announcement. We approved them in March of 2020, and then COVID hit, and we didn't want to lose their thunder while announcing them. And it just didn't work. So we're going to be announcing them soon. So right now we have about 45,000 individuals in HCMA recognized Center of Excellence care throughout the country. We have a few that are coming up. We have, I think I have 8 or 9 applications on my desk right now. And we're going to do our first virtual site visit the first week of December and see how that works. So we have new programs coming up, and the new program coming up will be in Tennessee. It's actually not here as a dot yet because I just talked to them the other day. And then we also have Colorado coming back on board, Hawaii, which I'm really excited about because we don't have anything there. I spoke to a very fledgling program in Alabama this week. So we're trying to get care and a hub and spoke model into more communities around the country so that patients don't have to be lost and be dealing only with a community cardiologist and having to put all their eggs in that basket. That said, I cannot put out a big enough call for this. Community cardiologists are critically important. You need a good community cardiologist on your team. We don't necessarily want them adjusting all your meds and determining invasive therapies, but we need that good relationship at home for when things turn, they can work with your center of excellence and make sure that you're getting the best care possible. And when the center needs to communicate with your doctor or vice versa, that there's open communication. So this is what the HCMA Center of Excellence model kind of looks like. And yeah, HCM is serious, so we try to take it a little bit lighter with this stick figure model. And what happens in this program is you have a hocomologist, which name was coined by Dr. Harry Lever, and I like it. So in this case, your hocomologist would be Dr. Asher, who we have pictured here. And you would come into the center with your heart in your hand, and you would go through imaging, get an evaluation for EP, heart failure, genetics, mental health, we'd hope, and you'd go through this funnel and you'd land in a basket for a period of time. But what's important about HCM is that we do have a gatekeeper. When the hocomologist or the director of the program feels that they need to bring in their EP colleagues or their advanced imaging colleagues or their heart failure colleagues, they bring them in and then they work with them in a manner in which brings your care back to the Center of Excellence coordinator, because a very common thing that was happening early on in HCM was patients would get referred to electrophysiology, for example, and they'd go to EP, they'd get their device, and they figure that's the end of their journey. It's not. The arrhythmia issues are there, but the muscle issues must be attended to. And your hocomologist kind of balances your electrical problems, your EP problems, and your muscle problems, your structure problems, and make sure that the right people are brought into the program and helping you at the right times. So there's been a couple of different models that we've worked with over the years. Some have been more successful than others. Some have been less successful. The American Heart Association, American College of Cardiology are going to be rewriting guidelines. I have some mixed feelings on this one because they're defining comprehensive HCM Center of Excellence, primary HCM centers, and your primary cardiologist. And they're trying to help define the roles of each of these individuals. So for diagnostics, everybody can have a role to different degrees. Advanced imaging, the same. And you see that a Center of Excellence model with high volume, which to us is defined at 600 patients or more, that they've seen through the program, not in their institution's database, in the program. That's a center of excellence. That's your 10,000 hours of really working HCM patients. A primary care may just have a lower volume and maybe evolving to a center of excellence model when they get the volume there, or they may never get there. Some of them don't have surgery, some of them don't have transplant, and they will have referral situations to higher volume centers. And those program models represent probably about 30% of the HCMA centers. Because of their location, we've taken them on so that there's good care for patients in that community. Your primary cardiologist can help in diagnosis. They can do some imaging, although we do not prefer the echoes being done by the primary cardiologist. But Holter monitors and event monitors can be done at the local cardiologist, and they should be kept involved in your care. From a patient's perspective, we know that patients treated in centers of excellence have better care. They're doing better emotionally and physically. Their outcomes from invasive procedures have lower complication rates, and they have the ability to participate in clinical trials and research opportunities. Sorry, this is kind of, that's the patient perspective. What we factually know is that there are better outcomes from surgical myectomy and alcohol ablation. There's data out there that says 1 in 8 myectomies done in low volume centers literally end in disaster. We don't have nearly those numbers in centers of excellence. In fact, it's more like a 99% likelihood of a successful outcome. There's a higher likelihood patients are going to be treated with the appropriate level of care, and that they will be removed from therapies that are contraindicated or inappropriate. To this day, we still have people being given digitalis and lots of vasodilators that can actually make their HCM worse. So I'm going to pivot to some of our social media platforms. For some of you, you're watching us on Facebook right now. Anytime that the HCMA has a page, so we have our official page, a group, you will notice that it's going to have the same heading. So you know that you're still in an HCMA environment, which means it's moderated by trained volunteers, and that you can immediately access the HCMA staff in office with any questions that you might have. We are going to be working on international groups coming up soon. We're starting, we've just this week, it's not out yet. We have our poster translated into Swedish and Spanish finally. So those will be available soon. And as each international program becomes available, they will also get a Facebook group that they're going to be building up. We're going to be working on our online support programs. We have, I think we have 14 of our volunteers trained and ready. Now we're working on deployment. Julie and I are going to be working on this next week. We hope to get it done in September, but we didn't quite make it. There's a lot of logistics to get all these people trained up, but you're going to be able to come on to our HCMA support group system, and you are going to have different moderators. We're looking at our moderators kind of like radio show hosts. They're each going to have their own vibe and their own just topics that they want to kind of stick with and their way of dealing with things. So you may have to like pick and choose and go to a couple different groups to find the one that's the right fit for you. But I will be holding a monthly pre-myectomy Facebook support group, or I'm not sorry, not Facebook, online support group. I might even tap some people, you know, like Nick or something to come join us once in a while in those groups. And then we'll talk it out before you go. Normally for the past 20 some odd years, I've done a pre-myectomy call with our members. It's like an hour each person who's gone through myectomy. We give them milestones on what to expect and just kind of walk them through the entire process. But in this group, we're going to have some post-myectomy people who will be there to share their experiences as well with the group and let everybody ask their questions. Our goal is that you can go into your surgery confident and secure and have all your questions answered, because the things you don't understand are really the scary things. The things that you understand and expect are less scary, and we hope that we can aid in your recovery and make that nice and easy. We'll also be talking about family issues, how to communicate with family members to get screened, how to get family members to understand bad days and good days, and how to have your friends not exclude you from social activities when we're allowed to have them, because your HCM is acting up. So we're going to talk about all those issues. We're going to be working probably starting in January on building this out in its entirety. Many of you have already participated informally in our peer-to-peer Bighearted network, but it wasn't called that. People would ask me, Lisa, you have somebody I can talk to who has this experience or that experience? And I'll call and I'll make sure that they can talk to you. It's getting a little hard to follow when there's 15,000 of you out there. I did well up until about 9,000, and then I couldn't do it anymore. So now we're going to have a match.com or eHarmony version of HCM. The mentors and the mentees will each fill out surveys, and we'll try to match you with a good peer. It may be a conversation on the phone. It may be a month-long relationship. It may be a year-long relationship. It may last forever. That's up to the two of you, but we'll get that organized for the beginning of next year. Many of you have heard Tales from the Heart, our podcast. On Wednesday of this week, I will be speaking with Robert Blum. He is the CEO of Cytokinetics, and we're going to talk to him about their clinical trials and why Cyto has gotten involved with HCM. And we're going to dig in a little bit into the discovery pathway from the business point of view in cardiology, and hear what they're thinking and how they're thinking, and how we as a community can work together in partnership to help develop new therapies for those with HCM. We're also going to be doing some other podcasts. Every month, I meet with Harry Lever on podcasts and and Marty Marin on podcasts, and we talk about different topics of interest. And I will slowly be pulling in our other HCM experts from around the country to have in-depth conversations on matters of the heart. Tales from the Heart, get it? People think it's a dating site, I found out, but no, we're really talking cardiology. And you're noticing something in our artwork, and I'm going to challenge you at the end to see if you can figure it out, and I will tell you later. But if you looked at the graphics for the Bighearted tour, and you look at this graphic here, there's something there that I will explain at the end if somebody asks me. Okay, we also kicked off the first year of the fully functioning Elizabeth T. McNamee Legislative Committee of the HCMA. We're going to be working on legislative initiatives that will enable us to help change state level legislation in the well child exam area to include cardiac evaluations, improve student athlete protection, and provide professional training. We are going to train our volunteers how to speak to their elected officials on the facts related to why we need to do this. We have created a 200 and some odd page report on each state, broken down. What have they done? What can they do? Who are the people? Who are the players? And we are going to give you a plug-in system that will have letters already written, and all you have to do is engage with your elected official. We also want to support good AED, CPR, Good Samaritan coverage. And on the federal level, we need to support health insurance coverage for pre-existing conditions. We need to work with the FDA, CDC, and other agencies on matters related to clinical trial discovery, patient safety, and related items. So we're starting on the state level, but we're keeping our eye on this federal issue. And on November 10th, we're going to learn a lot more. The Supreme Court is hearing a case on the Affordable Care Act, and about 10% of our population get their health care through the ACA. And if it's to be dismantled, 10% of our population will find themselves uninsured. So we need to advocate on their behalf to ensure that they can stay in an insured system so that they can get the health care that they need and deserve. Okay. For those of you who participated, thank you. For those of you who have not seen it yet, back in June, it was supposed to be April, thank you, COVID, we held our externally led patient-focused drug development meeting with the FDA, and our report is going to be issued shortly to the FDA. It's a written report that gets sent after the actual presentation. If you've not watched it yet, it's still available on YouTube. While we're closing to public comment that will be included in the report, you're always welcome to provide your comment, your experience, and we can categorize that in our data. And it's something that it's really the basis of which we're making our arguments that mental health services need to be improved for those with HCM and their families, that discovery needs to be fast-tracked because many people don't have any other options than what's available, and it's not good enough. And transplant is nice, but it's not really an option for the masses, and it has its problems as well. So we want to make sure everybody has seen that, and I'm going to finish there. I'm going to thank our partners at Cleveland Clinic, and some of them are our longest partners ever, and all of our HCMA Recognized Centers of Excellence program who do such a great job at taking care of our patients, our board, our volunteers, and Brandy, who is my donor and without whom I wouldn't be here today. So thank you all, and I'm going to hand it over to Craig Asher, who I can tell you I have had the pleasure of knowing. It's got to be 20 years now, because you were training with Harry, and it has been a long road because you started up in Cleveland and then you went down to Florida, and I'm like, I don't want to lose you because you know HCM. But then we finally got the center set up there, And then we figured out the ways to bring in the newbie, who was trained by Chris Kramer, another HCM guy from UVA. I remember that. And then Nick can fly down to Florida and get out of the cold weather in Cleveland, which I think is why I think the next trip is February, right? In the middle of the snow. So let's just take a look at the polling real quick. A couple of you did it, and I'm going to share the results before I hand it off to Craig. So Craig, you can get your camera set up or your presentation set up and do a screen swap like we did last night or in our trial, because we were looking at your other version. So just hit that little button up top. So most of us are from the Northeast and Southeast. So we've got the East Coast covered this morning. Some from the Midwest. We have somebody joining us from Asia and somebody on the West Coast. So we've got some diversity in location. We also have mostly patients with us, and some of them are patients who have family members who are also affected. And we have somebody who's working for industry. Hello, industry partner. What is your experience? A few of you have been diagnosed in the last 2 years, and that's the hardest time for HCM. That's when, you know, we're trying to figure out this whole new world, change our lifestyle. So hang in there. We're here to help you. There will be a support group just for you too. Most of you are taking medication. 17% have ICDs. 28% have also already had an alcohol septal ablation or myectomy. 33% are AFib. 17% of us have lost family members to HCM. 61% have had genetic testing. And there's a couple who have been advised for septal reduction therapy, but they haven't done it yet. So that's who we've got here today. I'm going to hand it off to Craig. I'm going to tell you to unmute your mic. And I'm going to make my screen black.
Okay, thank you, Lisa. Do you see my full screen now?
I see it perfectly. It looks great.
All right, great. So what we need to know about you and how we can help you. Again, an overview of hypertrophic cardiomyopathy. So I did want to tell you a little bit first about how I got interested in hypertrophic cardiomyopathy. So I was born here in Springfield, Massachusetts, and I'll tell you why that's important in just a moment. And then I went here to UPenn, then back to Massachusetts, to Tufts in Boston, and then to Emory for training, and then to the Cleveland Clinic in Ohio, and eventually down to the Cleveland Clinic in Florida in 2004. And you may not know this, but Springfield's not known for very much, but it turns out it's where basketball was invented by Dr. James Naismith. And there's a beautiful building there. This is the Basketball Hall of Fame. And so growing up in Massachusetts, I was an avid fan of basketball, and the team in Massachusetts is the Boston Celtics. So in 1993, after a tragic sequence of events, one of the star players, all-star players for the Celtics, Reggie Lewis, died suddenly at age 27. And the cause of death was thought to be hypertrophic cardiomyopathy. And around that time, I had the privilege of working with Dr. Harry Lever. As Lisa has said, he's, we would say, the father of hypertrophic cardiomyopathy at the Cleveland Clinic. We used to call him Hollerin' Harry, just because he was so passionate and so dedicated to caring for patients with HCM. And so these were the sparks that got me interested in taking care of patients with hypertrophic cardiomyopathy. So what is hypertrophic cardiomyopathy? I usually tell patients that you break down the words. So hypertrophy means thickening, cardio means heart, and myopathy means a muscle disorder. So hypertrophic cardiomyopathy is the unexplained hypertrophy or thickening of the heart muscle usually over 15 millimeters or 1.5 centimeters. And get these to play here. So this is a normal heart. And sorry, that's not playing right now. This is a normal heart, and you can see the white is the muscle, the black is the blood. And on the left, you see a patient with hypertrophic cardiomyopathy where there's severe hypertrophy, severe thickening of the septal wall. So nomenclature is important, and you will see these old acronyms, IHSS, ASH. We don't use these very much anymore. We like to use the terms HCM or HOCM, where the O stands for obstruction. And sometimes we will refer to atypical variants of hypertrophic cardiomyopathy, where people have some criteria, but perhaps not all the criteria for hypertrophic cardiomyopathy. So our objective, our first objective when we first meet somebody is to trust but verify. And Lisa already talked a bit about this, that there are many mimics of HCM, these are just some of them. High blood pressure causes thickening of the heart. Sometimes we see thickening related to just getting older. On the other end of the spectrum, athletes have enlarged hearts, they have thickened hearts, and then there are many other possibilities. This is an example of 3 patients that were referred to us with a working diagnosis of hypertrophic cardiomyopathy, and each one of them had alternative diagnoses or mimics, a restrictive cardiomyopathy, amyloidosis, and Fabry's disease. So in order to trust but verify, what we need from you is we need written records, but more importantly, we need a CD, we need a disc, a thumb drive. We need to see images of your echocardiogram. And if you've had a stress echo, a cardiac MRI, a cardiac cath, we need those as well. And if possible, we'd like to see those in advance. So the next objective when we meet somebody is to characterize the type of HCM. And so there are 2 major types of hypertrophic cardiomyopathy. There's the obstructive type, and there is the non-obstructive type. About 70% of patients are obstructive. Sometimes that's evident at rest in about 40% of people. Other times we'll only see obstruction after we do some type of provocation, such as exercise. And further, we'll characterize the obstruction as being in the LVOT, the left ventricular outflow tract, or within the cavity of the heart. So obstructive hypertrophic cardiomyopathy is due to something called SAM, systolic anterior motion of the mitral valve. And so here, this is the septum, this is the muscle. This is the mitral valve. And you can see with each heartbeat that the mitral valve hits up against the septum. That obstructs blood getting out of the heart, which we can measure by a pressure gradient on echo. And it also may cause a little bit of leak backwards into the top chamber of the heart, the left atrium, and this is called mitral regurgitation. The next way that we characterize the type of hypertrophic cardiomyopathy is in terms of the shape and distribution of the thickening, the maximal thickness of the heart, where normal thickness is usually up to about 1.1 centimeters, and whether or not there's any primary abnormality of the mitral valve. This is an example of the different shapes or distributions of hypertrophy. On the left, you see what we call proximal septal hypertrophy. That's when there's a little bit of bulge of thickening under the aortic valve just before blood exits the heart. Here you see asymmetric septal hypertrophy. That means that the septum, the divider between the right ventricle and the left ventricle, is thickened disproportionate to other walls. This is apical hypertrophy. The apex is the tip of the heart. And then there may be symmetric hypertrophy where all the walls are equally thick. So the next way that we characterize the type of hypertrophic cardiomyopathy is whether or not the mitral valve is abnormal. The more typical type of hypertrophic cardiomyopathy is shown on the left here, where the septum is thick, but the mitral valve is normal. And a less common variation of hypertrophic cardiomyopathy is seen on the right, where the septum is normal or just maybe mildly thickened, but the mitral valve is very abnormal. In this case, you see it's the leaflets are significantly elongated. And treating each of these different types is very different, particularly when it comes to septal reduction therapies like alcohol ablation or surgery. I'm sure Dr. Smedera will talk more about these types of hypertrophic cardiomyopathy when they come to surgery. So the next objective is to define your profile. And Lisa already talked a little bit about this. There are many predominant pathways that some patients may go down, but they're not mutually exclusive. So some patients may have multiple different pathways, but I'll highlight that the majority of patients with hypertrophic cardiomyopathy have a benign, stable course and live a normal lifespan. And this is something that I'd like to leave as a take-home message for all patients when I first meet them. But others may have symptomatic obstruction and they may require medications, they may require septal reduction. Others may have predominant problems with atrial fibrillation and arrhythmia from the top of the heart, and they may require blood thinners, rhythm control medicines, and need to follow with an electrophysiologist. A less common pathway is to have congestive heart failure and progress to what we refer to sometimes as the burnt out phase of HCM. Some patients may have a strong sudden death risk, and we need to go through risk stratification for ICD. And then other patients may come to us either after they have been resuscitated from sudden death or unfortunately had a family member that's experienced sudden cardiac death. So the next objective is to better understand how you feel and what your primary concerns are. So the typical symptoms of hypertrophic cardiomyopathy are shortness of breath with activities, palpitations. That's the word that we use to describe when you tell us that your heartbeat feels abnormal, usually because it beats quickly, it beats irregularly. You may feel strong beats, you may feel pauses. Some people have problems with lightheadedness or dizziness. Others may have chest pain, either at rest or with exertion. A very serious manifestation of hypertrophic cardiomyopathy is syncope. Syncope is passing out, and that can occur either with or without activities. And interestingly, a lot of patients will have any of these symptoms that occur most often after eating, especially after eating big meals or after bending over. What concerns or questions do you have? Some people don't feel have symptoms and they just want to feel well. Others are worried about the impact on their job, on their lifestyle. Others are concerned about their family, the transmission. Of course, we get questions about exercise, whether somebody needs surgery, and whether you're at risk of dangerous problems. So the next objective is management. We really have three main pillars of management goals. The first is to treat symptoms. The second is risk assessment for sudden cardiac death. And the third is family screening. So we'll go through each one of these individually. The first is screening. So all family members with hypertrophic cardiomyopathy, first-degree relatives should be screened. And we have two options for how we can do that. One option is to do serial EKGs and echocardiograms. Usually that starts after the age of 12 and then is done about every 3 to 5 years after age 21. And the alternative option is to do gene testing. And perhaps we can talk about more about that during the questions. That's a very detailed, comprehensive discussion that we have. So with regards to sudden cardiac death risk assessment, we have algorithms from the American College of Cardiology, the American Heart Association, that help us decide who needs an ICD, an implantable cardiac defibrillator. We have all of these different criteria, but I'll call your attention to the three most important, which are a family history of sudden cardiac death, unexplained syncope or passing out, and a wall thickness greater than 3 centimeters. The European Society of Cardiology has put many of these different variables together in a risk calculator, and you can plug all of these in. You can come up with a risk of sudden cardiac death over 5 years, and this helps us with shared decisions about who needs a defibrillator. We do put a lot of weight on cardiac MRI. Dr. Lopez will speak more about this. MRI gives us a more exact number in terms of the maximal wall thickness. But we also look at the percentage of scar tissue within the heart. These are pictures of MRIs. The black is the muscle, the white is scar tissue. And the percentage of scar tissue can be calculated. And generally when it gets to be around 15% or greater, then we consider the risk of sudden cardiac death to be high enough that we would generally recommend an ICD. In terms of management, non-surgical, non-medical management, the keys are to drink a lot of water, avoid big meals, avoid dehydration. We usually say drink more and eat less. Limit alcohol, caffeine, stimulants, things like decongestants. As far as taking antibiotics prior to dental cleanings, there are different opinions about this. The guidelines actually say that it's not required, but I know that a lot of the HCM experts, and Lisa is shaking her head and says that, that it is important. Exercise, we encourage exercise, but that does mean avoiding competitive and extreme levels of exertion. And we also talk to people about avoiding the perfect storm. That's a combination of many of these things above. So, not drinking much water, getting dehydrated, eating a big meal, drinking a little bit of alcohol, and having exercised earlier in the day. Sometimes that can lead to big problems. The medical management, the first line therapy is beta blockers. There are other options, calcium channel blockers, a medicine called disopyramide, and it's also important what medications we try to avoid. And there's a whole list of those. However, there are some exceptions. So for those people that have obstructive hypertrophic cardiomyopathy that are still symptomatic, that have failed medical therapy, and that have gradients that are over 50 millimeters of mercury, we have three options. The first is surgical myectomy. Dr. Smedira will talk more about that. The second is a procedure called alcohol ablation. This is a catheter-based procedure. We tend to think of this more as a second line option for patients that can't or don't want to have surgery. And then our third option now is to be part of a clinical research trial with a new medicine called mavacamten. So this is a tarantula. I hate spiders, but we've learned some important lessons. And it's an interesting story that scientists in Venezuela and in Boston found that there's a protein, a contractile protein in the limb of the tarantula that's very similar to the muscle cells, the sarcomeres that are within the human heart. And this led to a better understanding of the pathophysiology of hypertrophic cardiomyopathy and to the development of a new drug, mavacamten. And what they learned is that if you look on the left here, this is a normal sarcomere, a normal muscle cell. It's made up of these thick filaments called myosin, thin filaments that are called actin, and they have these cross links that are kind of like oars. They slide the muscle fibers along one another. With hypertrophic cardiomyopathy, the pathophysiology is thought to be that there's a lot of these oars, and so it causes a very excessive contraction of the muscle cells. So exaggerated contraction, a hypercontractile heart, and that results in a heart that also relaxes very slowly. And mavacamten, by binding to these thick myosin fibrils, essentially sets this back to a normal state. So there have been several trials that have looked at this new medicine called mavacamten. Currently, there's a trial called the Valor HCM study that's run through Cleveland, Dr. Desai, Dr. Nissen. It's a randomized, double-blinded, placebo-controlled study. That means at least for the first 8 weeks, you don't know if you get the drug or you get a sugar pill. But after 8 weeks, all patients get to have the drug. And it's for patients that are eligible for septal reduction therapies like surgery or alcohol ablation. And thus far, the results have been very promising, significant reductions in the gradients. People seem to feel better. The side effect profile seems very good. And so some have asked the question, is mavacamten the non-invasive scalpel of the heart? And so this is set up kind of a matchup in terms of how we'll treat HCM with obstruction in the future. Will it be the spider and mavacamten, or will it be the surgeon, Dr. Smedira? So I'll leave you now with some take-home points. What every patient needs to know with hypertrophic cardiomyopathy. First, as Lisa said, we used to think of HCM as occurring in about 1 in 500 people. The latest studies actually suggest that that's more like 1 in 200 people, so not an uncommon condition. Second is that the HCM is variable in presentation and in course. HCM is treatable and compatible with a long life. HCM sometimes requires intervention, surgeries, pacemakers, defibrillator, alcohol ablation. HCM may be unpredictable. We have calculators, we have ways to predict who's at risk for sudden cardiac death, but they're not perfect. And so sometimes we may err on the side of caution. It is important to stay educated and to educate the ones around you about your condition. And then finally, I think, as Lisa said, I've been around hypertrophic cardiomyopathy now for about 25, 30 years. And I will tell you that it's actually, I think, the best of times in terms of education, support, advocacy, clinical care, and research over in 2020. So a lot of that credit goes to the HCMA. So I'll stop there, and I think we'll leave questions for later on.
Fantastic. Thank you so much. I'm getting a co-host here. It is Shakespeare, the cat extraordinaire, who has decided to make an appearance this morning. Sorry about that. He is kind of a pain in the neck. Bad timing. Okay. Thank you so much for a very comprehensive overview and talk on how you got involved. I actually knew that Boston connection, or the Massachusetts connection, and gathers. I forgot about that until then. And here's an interesting side note. The night that I think it was he and Hank Gathers and Reggie Lewis died within what, like 24 months of each other. It's in a short period there. And Julie, who is now our volunteer coordinator, and I've been friends for many, many, many years. And we were together on New Year's Eve. And they were doing a recap of the year. And I had seen that video over and over and over again of Hank Gathers dropping dead. And I knew I had the same condition as Hank Gathers had at that point in time. And it's one of those there, but for the grace of God, go I moments. And I remember that New Year's Eve, we were in Hackettstown at your in-laws' house or whatever. And it was horrible to watch that clip. I had to leave the room and like collect myself, because it was scary that that was the same disease. And I was, close to the same age. So it was scary when it hits that close and you don't know it. And, the HCMA was nothing at that point. It wasn't even a thought at that time. So it shows how far we've come in a short period of time, going down our own paths and then coming together to help the community, which is awesome. So let's flash forward 2 decades or so, and I'm at the International Summit on HCM, and it's this Saturday night or Friday night, I forget, social. And I'm sitting there talking to these 2 young men, and I'm like, oh, these are my fresh ones. Let me go attack and see what they're up to. And then I find out that both of them have been trained in advanced imaging, MRI, by Chris Kramer, who is somebody I deeply respect, out of the University of Virginia. And one was heading to Cleveland and the other was heading to San Diego. And earlier in the Bighearted tour, you heard from the other advanced imaging guy that was part of that conversation that night, with a couple of glasses of wine involved, I suspect. And that was Jorge Gonzalez. And the other was David Lopez. So I got to meet him, I guess it's like 3 years ago now there. We were supposed to be at the summit last week. It's now been pushed forward to next October. It will be virtual, and there will be a Saturday night event again, but the HCMA is going to run it. Stay tuned for more information on that, because it's going to be fun and there will be wine involved, because, hey, you got to have some fun, even though it's HCM. So David, I'm going to hand it off to you to talk about advanced imaging a little bit more and take a deeper dive. Thank you so much.
Thank you, Lisa. Oh, it's just I can't share my screen. All right.
Should let you do it now. I turned off my mic. Sorry. There you go.
All right, there we are. Excellent. Let me minimize my screen over here because I can't see everything. All right, thank you, Lisa. Thank you, Craig, for having me here. So yes, I did train at UVA with Dr. Kramer. I did most of my postgraduate training there, the internal medicine, cardiology, and then advanced imaging in cardiac MRI and CT. I am a specialized in multimodality imaging, but I am a clinician as well. So I do share my time between clinic and also interpreting studies and performing studies. And so today, I'm going to talk to you about tests and procedures that may need to be done in the course of the evaluation of the management of HCM. So as has been sort of mentioned before, there are sort of two major pathways in which patients arrive to us in the cardiology clinic, and a large group is going to be asymptomatic or have no awareness of disease, and basically it gets identified by some ECG or electrocardiogram that's performed for an operation or some part of screening or employment screening. They may have an echo done for other reason. There may be a family history, and so they're undergoing screening. And also someone may have heard a murmur, primary doctor or some other physician hears a murmur, and then they get referred. And then the other group is someone who is having a symptom or having some complaint, some discomfort, and so they present to us for evaluation of that complaint. And that may be shortness of breath, chest pain, palpitations, passing out spells, or syncope. And once we see those patients, then we start an evaluation process. And you may come with different kind of information for that evaluation. It may be a new evaluation, nothing is known, or you may come for a second opinion, or some studies have been performed. And so as we go through the visit and we talk to you and we review what's available, then we decide on a battery of examinations that we think are going to be beneficial to further understand the condition, but also in the management, depending on what we're seeing. And so these are sort of the list of tests that we generally end up doing one point or another in the evaluation of HCM. And it goes from the most basic to an electrocardiogram, echocardiogram, stress echo, CMR, some form of rhythm monitor, genetic testing, and then catheterization with angiography. And so we'll go through each one of those and what they entail and what information we're going to draw out of them. And, you know, as you listen to that list and you go through that, you probably are asking yourself, or someone has asked me, do I need to have all these tests? Is that necessary? And then oftentimes the question is the test safe? And so we'll touch on that. And, you know, the short answer is that yes, each of those tests are necessary at one point or another, not for everybody. And these tests are safe. And when used for the proper indication, then the benefits are much greater than the risk. As has been mentioned before here now a couple of times this session, the goals of our initial evaluation with the cardiac testing are to first establish a correct diagnosis. And so it's already clear HCM that presents in the, there are many conditions that present appearing like HCM. And so we're trying to see if this HCM or a mimicker. We're trying to identify your HCM risk profile. Is there obstruction, atrial fibrillation, and so on. Very important is to understand the risk of sudden death. And so we do a series of tests to assess for that. And then we want to do some family screening once the condition is confirmed. In follow-up, we're going to be doing some additional testing to monitor the progression. We want to assess the treatment response, and we want to perform longitudinal risk stratification as the condition changes over time, because your risk may be low today, but maybe in a couple of years that risk changes. And we want to evaluate any new symptoms that come up. The most simple test that is performed is an electrocardiogram, and this is often the first reason why somebody gets evaluated for possible HCM. The electrocardiogram is a electrical recording of the electrical activity of the heart. There is a normal pattern to this electrocardiogram, and in the setting of HCM, there are some characteristics that tend to be typical, but the test is not specific and is not very sensitive. So some people may have what appears to be close to a normal electrocardiogram and have HCM, and others may have a very abnormal ECG, but the heart structurally appears to be close to normal. The electrocardiogram uses these electrodes that are placed in the chest and then maybe the arms, and that is a very quick test, takes a couple of minutes, usually done in the office during an initial visit. From there, once we have a suspicion of HCM, the second test that we do on our first line imaging test will be an echocardiogram or an ultrasound of the heart. Usually it's going to be a transthoracic echocardiogram, meaning that the ultrasound probe goes in the chest area. And in this test, we're trying to look at the wall thickness of the heart and see if there is in fact hypertrophy. We're trying to look at the shape of that wall thickness and what distribution. And we're trying to see if there is different patterns that may convey a different risk for sudden death, like apical aneurysms. And we're trying to assess the pumping function of the heart or the systolic function of the heart. We're also looking, as Dr. Asher mentioned, to see whether there is systolic anterior motion of the mitral valve, or SAM. And in this image here, you can appreciate the mitral leaflets, how during the contraction of the heart muscle, these leaflets are dragged into the outflow of blood through leaving the ventricle. And on the color image here on the side, we see the turbulent flow as it's been obstructed, leaving the heart. And then there's also concomitant regurgitation of the mitral valve because that leaflet is being pulled forward and now the valve is not closing properly. And as we do that, we want to know whether this is causing obstruction of blood flow. And we define that by the pressure difference between the ventricle and the aorta, which we assess with a modality of echo, which is called Doppler. And on the Doppler, we're looking at the velocity of the flow out of the heart. And the higher the velocity, the greater the pressure inside the ventricle and the difference with the aorta. So if the gradient is in excess of 30, then we'll consider that there is some obstruction. Greater than 50 will be significant to cause symptoms. And so someone may have SAM, but may not have obstruction. And so we want to confirm that. So on the day of the echocardiogram, there is no special preparation needed. It takes about 45 minutes. We often need to use an intravenous catheter or an IV in order to inject a contrast agent for echo. This is a type of contrast that are microbubble or microspheres that enhance the image quality. We often use some provocation maneuvers to try to look for that obstruction and gradient. Use the Valsalva maneuver, which when we ask the person to bear down. We may use a medication called amyl nitrite, which also provokes this gradient. From the echocardiogram, we often use a more involved evaluation of the heart called exercise stress echocardiogram. And so in this case, we are gonna use the exercise as a provocation maneuver and trying to evaluate if there is a provocable gradient. In the case that during the rest echo, we did not identify a gradient even with those maneuvers. Now we're doing exercise to see if there is a gradient during exercise. We want to know what your exercise capacity is, as this has implications on how the disease course will progress. I want to know your blood pressure response to exercise. If it's a follow-up examination, trying to assess the response to the treatment. And if the person is presenting with some complaints, then it helps us evaluate symptoms. Now, in HCM, you may have heard stress echo or stress test. It's often the test that's done to evaluate for coronary artery blockage. But in this particular condition, stress echo is not very helpful to find out that information. So The goals here are mostly, as I mentioned before, looking at the blood pressure, exercise tolerance, and the gradients, but not for evaluation of the heart arteries. So the exercise stress echo is part a rest echo and then exercise. So we start off with a rest imaging, and then we'll ask you to exercise, often on a treadmill. During the examination, we're constantly monitoring your heart rhythm, looking for any heart rhythm abnormalities that may develop during exercise or after exercise. We're monitoring the blood pressure constantly. And then as soon as you reach your maximum tolerance of exercise, then we'll have you come back quickly back on the table, and we'll take some additional images looking for that gradient in the outflow tract or the LVOT. This test will ask you to come fasting, but mostly referring to solids. We do want you to be well hydrated for the test. We don't want you to come dry to a run. So it's important to stay hydrated. The test takes about 60 minutes, you know, as you're taking rest pictures, exercise, and then the recovery period, you know, we observe for a little while after the exercise. We want you to come in comfortable shoes and clothing. And again, we might use an IV during that test to enhance the image quality. So from there, we often escalate our evaluation to cardiac MRI. And cardiac MRI is a comprehensive examination of the heart. We have the ability to get a lot of the information that we get from echo. So the shape of the heart, the wall thickness with high accuracy. We also can assess for the systolic anterior motion, the SAM, as you can see here in this image, the mitral leaflet being pulled into the LVOT and that turbulent flow. With different techniques, we can measure the velocity as well and estimate gradients, although not as accurately as with echo. And so that's one big part of MRI. So if someone has technically difficult echocardiograms, the MRIs will allow us to evaluate the heart very clearly. And there are some blind spots on the echo in which we don't see the wall thickness very well, and the MRI will shine some light on that. Now, where MRI has stood out from the other modalities is in the ability to identify fibrosis within the heart with the use of gadolinium contrast. These are tissue, microscopic pictures of the heart muscle. On this panel is a normal heart sample, and the myocytes are aligned in parallel. This is a heart with hypertrophic cardiomyopathy. And you see that this the disorganized arrangement of the myocytes, and there is a lot of space in between the muscle cells. And in this space, you build up fibrosis or deposition of fibrogen, and that's this in blue in these images with this special stain. And the gadolinium contrast enhanced images allow us to visualize areas where there is significant accumulation of fibrosis. And so gadolinium takes longer to wash out in these areas. And so when we take pictures after 10 to 15 minutes of administering the gadolinium, we can see where the gadolinium is getting stuck. And so in this particular sequence here, the muscle cells without significant fibrosis look black, and the areas where there is fibrosis will look white. And we try to quantify how much area of fibrosis is in the heart. And so this is referred to as late gadolinium enhancement, or LGE. And it has been shown over the last 10 years to be correlate very well with the risk of sudden death, and has emerged as an important step in the assessment of sudden death risk. So some caveats about CMR. It is a non-ionizing technology, so you're not getting radiation. So for if there was a need to repeat testing, there isn't radiation exposure. We use gadolinium contrast, which in contrast to compared to CT scans where we use the iodinated contrast, this is gadolinium. The gadolinium is safe to use when there is kidney disease. For a long time, there was a concern about a condition called nephrogenic systemic fibrosis. With newer gadolinium contrast agents, it's safe to administer that, and we are performing gadolinium-enhanced studies in patients with advanced kidney disease, if there is an important clinical need for it. Claustrophobia is a concern. About 10% of folks referred for MRI will experience claustrophobia during the exam. If you know that you have claustrophobia, tell your doctor, and we can prescribe an anxiolytic that you would take about 30 minutes before your exam. We don't want you to be completely asleep during the test, but we want you to be relaxed and be able to complete the examination. Foreign metal, ferromagnetic foreign objects can be sometimes a contraindication. We will go through a screening process to try to see whether the exam can be performed. The most common foreign object here in our population is implantable cardiac devices, such as pacemaker, ICDs, and loop recorders. Prior devices were not designed to be used in the MR environment, but over the past 3 to 5 years, increasingly, mostly MR conditional or MR safe devices are being implanted. And so it is now much easier to undergo a CMR examination if you have an ICD or a pacemaker. Then the next obstacle was that the device will cause a lot of imaging artifact. And so here's an example of a late gadolinium enhanced image. Here's the devices in this area, and it's causing a whiteout of the area of the heart here. And as you recall, white in these images tends to mean fibrosis, and in this case, it would be a false result. But we now have newer sequences that allow us to eliminate that artifact, and we can get good quality diagnostic images with defibrillators. For the CMR test date, we'll ask you to come fasting again. Clear liquids are fine. The test takes about 45 to 60 minutes. We will place an IV catheter in order to inject the gadolinium contrast. So away from the imaging, we do want to monitor or assess heart rhythm abnormalities. And so most commonly for the assessment of non-sustained ventricular tachycardia, but we also may do monitoring to screen for atrial fibrillation or to assess palpitations and syncope. And the monitors, there are various modes of doing this. The traditional method has been a Holter monitor, which is worn for about 24 to 48 hours. It's a cumbersome device. You put multiple leads in the chest and you wear that during that time period. Newer methods have emerged, like these kind of patch devices that can be placed easily on the chest. This particular one will stay on for about 2 weeks. There are other ones that you put electrodes and snap on with 2 points of contact, and you can wear them from 7 to 30 days. And so if you wanted to have a longer monitoring period, that's an option. In some cases, we're trying to investigate a symptom of syncope that may be sporadic, but concerning. And so we use implantable loop recorders to allow us to identify normal rhythms over a longer period of time. This is often used also for the evaluation of cryptogenic strokes to look for atrial fibrillation. And so these devices are implanted on the left chest area over the heart, under the skin, and they last for about up to 3 years. So we mentioned genetic testing evaluation earlier. The genetic evaluation is important a lot of times in the diagnosis as we're trying to differentiate different forms of hypertrophy. But it's also very useful in the evaluation of family members. It does require not just a sample for the gene testing, but also counseling and discussion of the results, because these are not often easy to interpret. And so it's always very important to get both the gene testing, but also the counseling, which is very important. So here's an example of a patient recently evaluated here, and the genetic testing revealed that in fact The patient had Fabry's disease, and that was suspected based on MRI findings. So cardiac catheterization is not always done, but is used when there is a concern for heart artery blockages or in preparation for surgical myectomy or alcohol septal ablation, or also if we have some concerns about the accuracy of our echo and we want to precisely determine the gradient in the ventricle. And so when we say cardiac cath, it's a little bit of an umbrella term, and really there are two tests that are being performed or could be performed with a catheterization per se. One is an angiography in which we inject iodine contrast and we image the arteries and we try to assess if there are any blockages in the arteries. And the other one is what is properly a catheterization of the heart chambers. And we use this to transduce the pressure within the chambers and then make different evaluations. In this particular case, we're trying to assess if there is a gradient or a pressure difference between the left ventricle and the aorta. And that way understand the physiology of the hypertrophy. For this test, we want you to come in fasting, but you may take your medications with sips of water. If you're on a blood thinner, you may have to withhold that for the test, depending on the medication. It's an ambulatory procedure. We do use conscious sedation so that you're relaxed during the procedure. And for this reason, we want you to have somebody with you that's gonna drive you home after the test. So those are kind of a run through of the most common tests that we might perform in the evaluation and the treatment of HCM. And so these are some of the takeaways in summary. So as you may have already gathered through the different talks, the evaluation of HCM is complex and it does require multiple tests. One test cannot give us all the answers that we're looking for, and each test contributes different information that is valuable for the treatment. Our objectives initially are going to be to identify the cause of the hypertrophy, to define the HCM profile, to assess your risk of sudden death, and family screening. There's going to be a need for periodic surveillance after an initial evaluation, and that period may vary depending on the individual. And we'll also do some additional testing when symptoms come up or the condition worsens. And tests are safe. Their benefits are much greater than the risk when we're using it appropriately for the right indication. Thank you. Thank you, Lisa.
Thank you very much for that comprehensive chat. And we're going to next hear from our surgeon in the room. And oh, there we go. You stopped sharing your screen. Thank you so much. And now we have Nick, who has that perfectly placed seasonal photo or painting behind him. So I'm sure he changes it out every season. There's a summer, winter, spring, and fall, you know, full canvas.
That's why we have a fixed photo.
Yeah, right.
Yeah, that will work. Okay. So yeah, they're down in Florida with palm trees, and you're like, I'm not putting up the palm tree picture because I'm up here in Cleveland and there's no palm trees. Okay, so as I previously explained, and for those who are joining us a little bit later into the broadcast, Nick Smadera is the cardiac surgeon at the Cleveland Clinic who performs most of their myectomies, as well as transplant and other things, but we just like to think of him as an HCM surgeon. So in my mind, that's all you do all day long.
Wow.
So we're going to hear about septal reduction therapy with myectomy, and then we're going to get into some conversations. I encourage you all to use the question and answer feature at the bottom of your screen. You can submit your questions throughout this last talk, and we'll make sure that we address all of your questions at the conclusion of the presentations. Nick, I hand it off to you.
Well, let's see if I can do this.
If you can do a myectomy, I think you can do a Zoom share screen.
Yep, here it is.
And
How's
yeah,
that? Can
that's
you see?
perfect.
All right, awesome. Well, good afternoon, everybody, and congratulations, Craig and David. Great summation. I always learn something. I didn't know about Craig's journey, and I didn't know about the spiders. So I learned a lot. So I tried to do the big-hearted warrior rock star kind of theme. So I didn't shave this morning, trying to say, well, I look like just got off the rock star tour maybe, but I did get my haircut this morning, so I'm halfway there. But the journey I've been on for 25 years, treating patients with hypertrophic cardiomyopathy has been one of the most enjoyable, because we really can help patients feel better and potentially live longer. But also, we've learned an awful lot about the disease and also the physiology. And what I'm going to focus on is a bit of the physiology, because it's essentially, from the surgical point of view, a plumbing problem. You have a path, the blood needs to get out through this path of the heart, and something gets in the way. And for the longest period of time, we were always focused on the left ventricular hypertrophy. And I remember training under Dr. Lytle as a fellow, and I'd be in the operating room with Bruce, and I'd say, how come this person has obstruction? He doesn't have any hypertrophy. And we kind of just shrug our shoulders and say, well, we don't know why he has obstruction, but he or she has it, and we're going to replace the mitral valve as a solution. But it always puzzled me. It was like, well, if it's hypertrophy, why don't they have it? Why do they have obstruction? So that led to a lot of questions, working with Harry and Craig and David and my imaging colleagues, to ask questions about why would you have obstruction if you don't have hypertrophy? And I'll get to some of that a little bit, but it's been a marvelous journey. The other point, I did some math when, we think about 1 in 200 individuals impacted by some form of this disorder. And there's 11 million residents in the state of Ohio. So just in Ohio, if you do that math, that's about 44,000 folks that might have a condition that warrants some sort of investigation. So an incredibly large number. So here we go. This is a picture, and you've seen a number of pictures, so I won't dwell on it. But the key factor is this area right here, which is the path that the blood needs to take to get out of the heart. And it's bordered by muscle in the mitral valve. And anything that results in those two things coming together results in some form of narrowing or obstruction. And that's all it takes to develop symptoms related to what I call outflow tract obstruction. It could be hypertrophy, and it could be something with the mitral valve, or these things here, which are called the papillary muscles. And between those three entities, we've spent a lot of time in the recent years trying to figure out what leads to obstruction. But when I give a talk, I always like to think about the history and the evolution of the thinking around the treatment of this entity. And this is a slide showing back what the surgeons thought about in 1961 on how to treat this. This figure shows extreme hypertrophy, very, very minimal chamber here. And before we had all the advances in cardiopulmonary bypass, the surgeons had to quickly go on the heart-lung machine, or not even go on the heart-lung machine. And what this shows here is the surgeon taking his finger and putting it inside the aorta, and attached to the tip of his finger, it's barely discernible here, is a knife blade. This knife blade was then inserted blindly, and he would just make a slit in this thickened muscle here, and then take the knife off his finger and put his finger back in the heart and split the muscle with his finger. Just go from a slit to a fractured trough, with the idea of generating increased space for the blood to get out of the heart. It seems so primitive and what should I say, unguided when they did it, but that's all they could do at the time. And now we have all the advanced imaging studies that David shared with you that we use to guide what we do very, very specifically. So this was the next iteration. This was Morrow's operation, which takes out a piece of muscle in the septum, looking through the aorta. And another group, really the Houston group, Dr. Cooley, thought, well, you could also take the mitral valve out and put in an artificial valve, and that itself would eliminate the obstruction. This also shows a myectomy at the same time. So that we recognized many, many years ago, the mitral valve and the muscle played a role, and there were two competing approaches. One, get rid of the valve; one, get rid of the muscle or reduce the muscle. The problem we think of the valve approach is this is a mechanical valve you see here. It requires lifelong anticoagulation with Coumadin and blood tests to regulate the level of Coumadin. And we think this is not the ideal approach. We've been very pro mitral valve repair at the Cleveland Clinic. And that has led to my looking at what were the options in terms of mitral valve repairs. So this is the original Morrow description. You take a rectangular piece of muscle out right in the middle of the septum. But what we learned, both us and the Mayo Clinic and others, that was insufficient often to completely eliminate the obstruction, especially under stress when the patient exercised. So we advanced it, or I went forward after seeing some work done by Sir Magdi Yaqub over in the UK to extend the resection to go from trigon to trigon and completely encompass the extent of the septum, both not only left to right in this way, but also from what we call the base of the heart towards the apex. And you really have to get over the tip of the papillary muscles, which is shown here, in my estimation, to really be effective in reducing the gradient. So this is probably the most fun part of the operation or the show. This is I think it's 6-minute video that we put together. One of our chief residents now joining us on staff come next year, Kevin Hodges, and he also is interested in myectomies, and he's going to narrate the operation that we do. And you can see from my view as the surgeon going through the aorta, what it looks like.
This video demonstrates the surgical technique for extended septal myectomy. Here, the heart has been arrested with antegrade del nido cardioplegia and a transverse aortotomy has been made above the level of the sinotubular junction. 3 stay sutures have been placed in the aorta to facilitate exposure. The aortic valve, septum, anterior mitral leaflet, and subvalvular apparatus are thoroughly inspected. The myectomy is performed according to a 3-step approach based on the location of leaflet septal contact identified on transesophageal echocardiogram. This contact is commonly 18 to 22 millimeters below the nadir of the right coronary cusp. At this point, 2 parallel incisions are made 10 millimeters apart, 5 millimeters deep, and 15 to 20 millimeters long with an inverted number 10 blade. These incisions are connected using a number 15 blade, and a rectangle of muscle is excised. The edge of this excision is continued to the right trigone, staying well below the membranous septum. Care must be taken to note the thickness of the inferior septum seen in the echocardiographic 4-chamber view, because it is often thinner than the anterior septum seen on the long axis view. The anterior edge of the initial incision is then grasped and continued to the left trigone, removing another rectangle of muscle. The incision can be carried closer to the aortic valve in the anterior septum here, as there is no conduction tissue in this area. However, it is important to maintain a ridge of tissue, allowing the malleable retractor to grasp the LVOT. This ridge is excised later. Fine adjustments are made to the retractor throughout the procedure to maintain excellent exposure deep into the ventricle. You will notice that as each rectangle of muscle is removed, it is arranged on a towel in the patient's lap, reconstructing the septum as it has been removed. This process is then repeated deeper in the ventricle at the level of the mid-papillary muscle. The extent to which the myectomy is carried toward the apex is determined by the location of septal hypertrophy seen on transesophageal echocardiogram. We have found that the entire depth of the ventricle can be accessed through a transaortic approach. In cases of more difficult exposure, there are several techniques that are helpful. First, the left pleural space can be opened, as with harvesting an internal mammary artery. Additionally, one can use a folded Raytec on the end of a ring forceps to push gently on the apex of the heart and bring the septum into view. For apical myectomies, which we also perform through a transaortic approach, thoracoscopic instruments can be used to extend the reach of the surgeon. After the myectomy has been completed to the level of the mid-papillary muscles, the retractor can be repositioned and the ridge of muscle intentionally left below the left trigon to facilitate retraction can be excised. After ensuring that there are no remaining ridges of muscle or irregularities, the ventricle is irrigated, the aorta closed, and the results assessed under provoked conditions using transesophageal echocardiography. We accept a peak LVOT velocity of less than 3 meters per second.
And this is what a specimen might look like. We do put it on the towel, and I do that specifically so I can make sure I subtract the amount of muscle that I see here from what I saw on the transesophageal echo to define what the residual septal thickness will be. You can see here it's about 1.5 inches or about 4 centimeters in width from side to side. And we take it even 2 to 2.5 inches, 6 centimeters down towards the depth of the ventricle. This area here is focused in terms of the resection because this is where the longest part, this is opposite the longest part of the anterior leaflet of the mitral valve. So that's a typical myectomy specimen. And here's where things I think got interesting as we began to ask these questions about why do some folks have hypertrophy and outflow tract obstruction and others don't have much in the way of hypertrophy. And one of the things I began to notice was that there was the change in the angle between the tip of the heart, that's where, let's say, the force of ejection starts, and the aorta. And the alignment goes from being sort of in line to much more acute, especially as we get older. And I think it is impacted also by obesity. I've seen it impacted by folks who have had the left lower lobe resected for lung cancer that pushes the diaphragm up. But what we learned in this MRI study was the more acute this angle from the tip to the pipe, the aorta, getting the blood out of the heart, the more likely you are to have obstruction. So there's an anatomical importance to how what I think of as the pipe and the pump are connected. And you can see it on this MRI here where the tip is right here, probably should really be over here. And the aorta, just change it somehow, the aorta is here. And the blood has to take this right turn to get around this hump of muscle. And what I think happens is the more acute this angle is, the less hypertrophy you need to cause obstruction. We've also learned that this mitral valve, as shown here, can be drawn up, but more commonly is lifted up as it's pushed down and lifted up towards the septum. And that's why we have to take muscle well into the depths of the ventricle to change the vectors of flow that force this mitral valve up towards the septum. So that's critically important in my view of eliminating the obstruction. But really what was so interesting, this was in the late 90s, early 2000s, when we began to figure out ways to address that question I posed when I was in training. What do we do in a patient like this who has limited or no hypertrophy in the septum shown here, but develops profound obstruction? And I started to focus on the papillary muscles because this papillary muscle is not only pointing towards the septum, but it's only attached to the heart well towards the apex or apically based attachment. And I think that results in the ability of the papillary muscles to be very mobile and actually form like a sling and head towards the septum under vigorous activity. So again, we had the choice of replacing the valve, but you really don't want to do that for anybody, but especially somebody who's 18 or 19 and commit them to lifelong anticoagulation. So through a number of different iterations, and I didn't come to this as my first approach to repairing it, but it became apparent that I could take these papillary muscles that seemed to be loose. They were only fixed down here instead of along the wall, and bring them back towards each other and anchor them towards the, to the base of the heart. And this is what we call the papillary muscle reorientation. And you can see just from this visualization, they head up this way towards the septum prior to the procedure, and then they begin to be aiming back towards the mitral valve after procedure. So the simple idea is just direct their focus or where they are fixed towards the mitral valve rather than the outflow tract. And we've developed a number of different approaches to preserve the mitral leaflet at the time of treating patients that don't have significant left ventricular hypertrophy. And this is just an echocardiogram showing the results. The other thing I think happens to the mitral valve, it's a living structure and it's being pulled up towards the septum every beat for many, many years, and it actually grows and it elongates. And this is the central part of the anterior, or the tip of the anterior leaf of the mitral valve. And there's so much of this tissue. In this case, I just cut out what looks about 3 centimeters or 1.25 inches of excess tissue from the leaflet itself, and it's still left the leaflet completely intact in terms of how it functioned, but got rid of the obstruction. So that's my last slide. And what I think is most important is that as a patient, you go to one of these centers of excellence that Lisa has worked so hard to put together and have a comprehensive evaluation, and also have a surgeon that really thinks comprehensively about the left ventricular function and has been trained to do these techniques that I mentioned here. And the final thought for folks is I've had the opportunity to work both at Weston and at the main campus, we call it, in Cleveland. And one of the questions that's raised is it the same having surgery in Florida as it is at the Cleveland Clinic? And the Cleveland Clinic in Ohio has been the #1 heart center for 26 years. And I can attest that probably 80% or 90% of the folks I work with down in Weston actually trained up in Ohio. And when I've been down there and operated, I cannot tell the difference between the two places. The care delivered, the skill set, the professionalism in the operating room, in the intensive care unit, on the floors are exactly the same. And that is one of the goals of Dr. Cosgrove and Dr. Mihalovic, is that we have one Cleveland Clinic, that you cannot tell the difference where you are in the Cleveland Clinic health system. And I can attest to that is exactly how it is. So I'll hand it back to Lisa, and we can go to the next step.
Okay. Well, Nick, thank you so much for that amazing talk. And you always have those interesting graphics, and some people looked away, and that's okay.
Yes, yes, I know. Some people love it though.
I will say the majority love it. And here's the funny thing on YouTube. One of our clients who had surgery at your hand, and you recorded, you might remember Kevin from the Cayman Islands.
Yes.
And I disclosed that because he has disclosed his video on YouTube. We received a notice yesterday after like 7 years from YouTube that should have a age warning on it. And I sent in an appeal and I said, are you telling me that we can turn on any television station and watch somebody be blown away by guns, stabbings, and all this kind of violence, but looking at heart surgery is a problem? Just so you know, YouTube reversed. And they said, you're right. It's fine. So it's kind of funny. So even YouTube went, we're not sure about that. But then they're like, oh, yeah, okay, it's surgery. I do have a couple of specific surgical questions that have come up in the past couple of weeks, actually since our last time to chat here. Can you talk about unroofing and what is a myocardial bridge and how does that affect, how do myocardial bridges play a role in HCM, albeit rare?
Yeah, it's rare. Although when you do catheterizations, heart catheterizations, you often see some of what would be systolic compression of the mid portion of the LAD. With advances in some diagnostic maneuvers for looking at the flow reserve, we've been able to be more, what should I say, direct in who we think we should intervene on. We've used some earlier studies, like David mentioned, the exercise stress echo and other things to show ischemia. But if there's significant bridging, we go to this, I'll ask David to chime in too. We go to do some flow reserve studies. And if there is compromise, then we would proceed with an unroofing. It can be a really tricky and dangerous maneuver because the LAD can essentially reside in the right ventricle. And if to unroof it, you enter the right ventricle. Repairing that entry into the right ventricle around the coronary artery can be really challenging. David, or Craig, any thoughts? We've seen the bridging for a while. Anything different from what I said?
I mean, as you mentioned, the coronary perfusion of the heart muscle occurs during diastole. And so, although on angiogram, you will see that the artery is getting squeezed during systole, the heart muscle is really not relying on that perfusion at that time. And so it's often visually attracting, you see it and there is a problem, but physiologically, the blood flow to the heart muscle is not significantly affected by the bridging. You would have to have very high diastolic pressure, and then you would have impaired perfusion at that time. So yes, stress testing is a little challenging with HCM because of the increased muscle mass, but you could do a perfusion exam to see if there is abnormalities. A AFFR may be a good test in this situation to try to assess pressure difference. But again, physiologically, I think is very difficult that the bridging is going to be a cause of symptoms because the muscle receives the blood flow during diastole.
Sorry, can you hear me?
Yeah, you're good.
Okay. Yeah, I agree with David. There's really a whole spectrum of bridging. What you have to do is you have to define the length of the bridge, the depth of the bridge, especially on CTA. David could speak to this, but on CTA now, they're actually quite common. But most of them probably aren't physiologically important. And that's I think that's, the main objective is for us to kind of tease out which ones are significant, and probably it's really a low percentage of them that are.
Okay, we have a couple of other questions. Some of them are mine and some of them are from the audience. Another question that has come up, and I issue it to you all. Watchman in HCM for the treatment of blood clotting from atrial fibrillation. And this kind of ties into a secondary question to Nick as to how often are you clipping the left atrial appendage while you're doing a myectomy and you're there anyway? When do you clip? When do we think a watchman? And if somebody could explain what a watchman is, because it's not the guy who watches the door, it's a thing. If somebody could explain that to our viewers. And is there a role in HCM? It's been coming up quite a bit frequently. So can we address this?
Yeah, I can speak to first, what is a Watchman? A Watchman device is a device that's inserted through a catheter procedure, a percutaneous procedure that excludes the left atrial appendage. The left atrial appendage is that portion of the left atrium where blood clots form in about 90% of patients that have atrial fibrillation. And so it was a device that was devised for people that had contraindications to anticoagulation, so that they could get this device implanted after demonstrating by echo, by TE, after about 45 days that the device has sealed off that cavity of the left atrial appendage, then patients could be taken off anticoagulation. Most of the people that get these devices are elderly people that just can't take Coumadin. Either they've, the contraindications are things like major bleeding problems or risk of falling or major organ problems. I don't know that there's any specific data on patients with hypertrophic cardiomyopathy. I'm not sure there's any specific exclusion. I think generally we would prefer patients with hypertrophic cardiomyopathy stay on anticoagulation if they have any fib risk. In fact, for patients without hypertrophic cardiomyopathy, we use a score called the CHAD score to assess the risk of embolic events and base anticoagulation based on that score. With hypertrophic cardiomyopathy, we don't use that CHAD score because we believe everybody with hypertrophic cardiomyopathy that has had atrial fibrillation requires anticoagulation, independent of age or other risk factors. So I think we'd have a very high threshold to stop anticoagulation or to consider the Watchman, maybe just in people that had extremely high risk of bleeding.
Nick, what about left atrial appendages and how are we addressing those?
Sure. So anybody that comes to surgery that has had atrial fibrillation, we perform some form of a surgical ablation, whether it be a pulmonary vein isolation, which is I think of it as sort of a third of a maze procedure, or if they've had more problems with atrial fibrillation, we do a full maze procedure, both right and left atrial maze ablation. And in every one of them, we put a clip on the appendage. Now, we know atrial fibrillation is very prevalent in patients with hypertrophic cardiomyopathy over their lifespan. And in papers that Dr. Desai has written and others, we know that one of the predictors for worse outcome over the course of our follow-ups is atrial fibrillation. So there would be this sort of incentive or inclination to put a clip on everybody that goes to the OR for a myectomy. However, I have not been inclined in any of my surgical activities to do something prophylactically unless I know for sure it's been proven to be the right thing. So I have not put a clip on the base of the appendage if the patient hasn't had a history of atrial fibrillation. I don't know that's the right answer, but that's been my inclination. One problem with the clip, or it doesn't go on quite right, and then you have yourself a challenging situation. So that's how I approach it.
I don't know why questions that have never come up before all of a sudden come up like 4 times in a week from completely different people that never knew each other, and it wasn't on social media. But for some reason, that was like the top question. Do I get it? Do I get a clip? I'm like, how do you even know what it is? How do you know that?
It's a really, really good question. And you could argue or suggest that it's a good study question that we should think through about, since if we're operating on somebody that's 25 or 30 and with severe hypertrophy, and you know they're a high risk over their lifetime of getting anticoagulation, should we put on a clip that will reduce their rate of potential thromboemboli? It's a great question. Great question.
So I go back to the very first meetings that we ever had at the HCMA in a small conference room in Parsippany, New Jersey, and Barry Marion sat there with his notepad, and people asked lots of interesting and different questions because they were coming from the patient perspective. And within, it happened the first year, the second year, the third year, the fourth year, about 18 months after the meeting, there would be a research paper on the very topic that the patients brought up. And this is that collaborative relationship between all of us. How do we get to better answers? We all think of things slightly differently. And when we all communicate, it's amazing how far we can get. There are some questions posted in the question box. One is about left apical HCM and microvascular disease. The question is about medical management here, questioning mavacamten, which is an investigational drug that has only been used in very small groups of people. So we really haven't gone there yet, so we can't speak to that. But in terms of, I think you have to look at this in two questions. Apical HCM is one issue, and having microvascular disease is a second. First, Craig, would you explain to everybody what microvascular disease is, and what do we have in our toolbox to treat it?
Yeah, it's a great question, and it's unfortunately not, there aren't great answers. Microvascular disease refers to the small arteries of the heart. You know, the heart has the big pipes are the coronary arteries, and then the smaller vessels branch out from the coronary arteries. And a lot of patients with hypertrophic cardiomyopathy, the big pipes are okay, the big arteries are okay. Sometimes they're stiffer and thicker, the muscular portion of them is increased, but particularly the small vessels are abnormal, and since the heart is thicker than normal, these small vessels have to give blood to a much larger portion of muscle. And so a lot of people have this microvascular disease where there's abnormal blood flow into the muscle because of these abnormalities of the small vessels. How do we treat that? Well, we do try to use the same type of medicines that we use for other types of hypertrophic cardiomyopathy, like the obstructive type. So we do try beta blockers, calcium channel blockers to slow down how fast the heart beats, also to allow the heart to relax a little bit more easily. As far as medicines that actually work more directly on the microvascular system, there are drugs that have been studied to work more so on the cellular level, the energetics of the small blood vessels. There are drugs like Renexa been studied in a trial called the RHYME study. Mavacamten was studied in the MAVERICK study. It's a study of non-obstructive hypertrophic cardiomyopathy. However, the data is really very limited and mostly focused on biomarker type endpoints, not as much symptoms. So from a medical perspective, it's a challenging problem. We try to use the same conventional medical therapy, but I do have some patients where I've tried Renexa with some benefit, and perhaps in the future we'll have more data on non-obstructive hypertrophic cardiomyopathy using mavacamten.
Anybody else, or are we going to jump to the next question? This is a very interesting one, and this is a Nick question. Is there documentation showing any increased scarring that results from a myectomy? Can you explain what happens to the heart muscle when you cut it? Does it leave a scar like alcohol? Does it leave a scar like fibrosis? Does it leave anything at all?
Not that I know of. We cut right through the muscle. In fact, we cut through the arteries that go in the muscle, and on the echocardiogram, you can see those arteries bleeding, if you want to call it, into the chamber of the heart. In the rare case that we've gone back in after a myectomy, there's a very thin layer of healing tissue that would happen, but I don't believe that there's any fibrosis. There is evidence that there is regression, some of the hypertrophy in other areas of the heart after you eliminate the obstruction, but David might be able to answer that. I don't think you see anything on MRI after a myectomy, but I haven't formally looked at that.
No, we don't see any significant fibrosis after myectomy on late enhancement.
Yeah, this has always been, when people kind of weigh the pros and cons of alcohol ablation versus surgery, this is always one of the benefits of surgery, is that you're not creating a scar. With alcohol ablation, you do MRIs after alcohol ablation, and basically you've had a big heart attack. You have this very diffuse transmural scar that is potentially a nidus for dangerous heart rhythm problems.
I think that's important. So we have a question that's very specific, and I'm going to make it a bit more generalized. If somebody today is coming to the Cleveland Clinic, either in Weston or in Ohio, and they're considering a myectomy or considering joining a trial, the Valor trial, and full disclosure, the HCMA is in the midst of a contract to assist in the recruitment for this trial, as we did with Explorer and Maverick. We will also help find patients who are interested in participating and help facilitate that communication. So full disclosure, we are going to assist in recruitment. What should a patient consider before saying, I want to do a trial, or I just want to go straight to surgery? You guys have any thoughts on that? Craig, I'm going to call you out and start with you.
Yeah, sure. No, it's a great question. One of the nice things about the design of the current study, the Valor study, is that you can you're randomized to either the sugar pill or mavacamten for 8 weeks, and then everybody gets mavacamten after that. But at each of the evaluation periods, someone could decide that they're not feeling well, and they can leave the trial essentially and go on to surgery. So I think it depends in part on individual journey as far as the patient and how sick they are. If people are perhaps a little bit on the fence as far as how they feel, their quality of life, then it's reasonable to be considered for the trial. On the other hand, if they're extremely symptomatic and they've had a long history trying different medicines and really feel poorly, I mean, we still unquestionably think of surgery as the gold standard, and people after surgery just do really well in many regards. And one other final comment I'll make about that is that after a successful myectomy, we know that the risk of sudden cardiac death and survival, the risk of sudden cardiac death goes down dramatically. Survival matches age sex-matched populations So, there are those benefits, and those are obviously with mavacamten, all we know from some of the trials is that the gradients go down, and that's a good thing. People feel better, but it's going to be a long time before we have long-term data on how patients do.
It is a challenge. I've been saying since these concepts came up that I'm very happy to have more tools in our toolbox. I'm very happy to have more opportunities for patients to choose different paths for themselves. But I don't think we're putting Nick out of a job anytime soon, because no matter what the goals and their lofty goals at that is to do a myectomy and a pill, there's certain anatomy that's not going to work well with a medication. There's just, we think of HCM as just this thick heart. We don't think as much about the papillary muscles or the chordae or the flow of is the mitral valve hitting the septum, or is the septum hitting the mitral valve? And there's all this interplay that outside of the world of HCM sounds like we're picking nits here, but they matter. And the geometry of the ventricle matters, and the muscle matters. And we need more choices. We need more options. But Nick, don't hang up the scalpel anytime soon.
No, I don't think that'll happen. But if I look at it from the patient's perspective, I would not want to have my chest opened and have heart surgery if I could avoid it. And so I think there is such great value in understanding, how this medication works and where it's applicable. And maybe it'll be in areas and in patients we haven't even really considered as the information unfolds. I anticipate we'll continue to do an awful lot of myectomies to help patients that are profoundly symptomatic, and this might just be temporizing in terms of their well-being. But it's part of science, as we've learned so much with COVID, is that iterative approach and new knowledge that we gain as we do these things, which I think is so important.
I think it's a really good point you bring up is, we think from the patient community and the non-medical community that you guys have all of this stuff figured out. You know everything about everything, and the answers are all right there. And we're all learning in real time. We didn't understand how COVID was transmitted. Well, some people did, and they didn't tell us. And then we thought that it only did this or it only did that. And now we understand more of the short-term implications, the long-term implications. And I will tell you right now, I suspect for years to come, we have rheumatic heart disease. I think we're going to have COVID heart disease. And there's going to be these long-term implications of this myocarditis type event going on and what's going to happen later. And if you have HCM and you have COVID, and we've had a few of them, most have done pretty well. However, cautionary tale, and this is a one-off, but somebody who was low risk of cardiac arrest had COVID in March, had a cardiac arrest in May, and was resuscitated. So was there some cardiac implications there? They were worked up by a top center, no risk factors whatsoever. Does the myocarditis that could come after COVID affect the HCM heart? If you have HCM and COVID, please keep in very close contact with your specialists and make sure you're getting Holter monitors and you're really on top of this. I would honestly say, because nobody knows, I would just have a lot more follow-up the year after COVID, maybe every 3 months, 6 months, you need to check in, because we don't know what COVID's going to do to the heart. And I kind of went off on a tangent there, and sorry, but it made sense at the time. We do have a couple of other questions, and I'm going to make the call right now that we have 26 participants live on the Zoom room. So in a few minutes, we're going to stop streaming on Facebook, and we're going to turn off the recording of the meeting, and we will go to hand raises in the webinar to avoid any complications of leaving the room. And Julie just breathed a sigh of relief, going, okay, we don't have to worry about those technical difficulties. And I just heard her laugh, and she's in Pennsylvania and she's not on microphone. See, I told you so. So that's what we're going to, I've just made the call. That's what we're going to do. So a couple of other questions. Does the atrium shrink back to normal size after a myectomy?
I don't know. I'd ask David from the imaging perspective. I would hope it would with the obstruction gone, but I don't know the answer to that.
Yeah, I don't know the exact answer, but in looking at images, the atrium is not as reversible as, for example, the right ventricle is probably the most forgiving of the chambers. So when the right ventricle gets dilated for different valve reasons, it does shrink to a more normal size. And the same thing with the left ventricle with some valvular lesions. The left atrium tends to be more fibrous material, and it's sort of like once it stretches, it doesn't come back. It has less muscular tissue. So as the muscle tissue tends to be more, I guess I would say, recoil, but the fibrous tissue has less recoil to that. So I have not seen much in the way of remodeling, but certainly the years of obstruction would have an effect on the ultimate, size of the left atrium. So the earlier intervention will probably prevent adverse remodeling of the left atrium.
So the secondary question here is, does a myectomy help reduce the frequency of AFib or the likelihood of developing it later? I will put an asterisk on this saying, if somebody has developed atrial fibrillation immediately post-op in that first week or so, that's pretty common, and that shouldn't be viewed as something that's going to be a long-term effect. But does myectomy help relieve some of the pressure going up into the left atria? And have you ever, I guess we have looked at post-myectomy AFib burden versus pre-myectomy AFib burden, and it is slightly different, but the damage seems to be done earlier, and the left atrial seems to be dilated, and thereby it's just more proarrhythmic later. You guys want to talk on that?
Yeah, no, it's a great question, and I'm not aware that I don't know of the long-term data that looks at AFib prevalence and after myectomy long-term. I'm certainly not aware of any data that says that it's significantly less.
Yeah, there's the hint that when we start to look at treating patients that have gradients earlier and doing a myectomy, by doing the myectomy compared to waiting, and these are retrospective, observational studies, so they're not randomized trials. There seems to be a reduction in cardiovascular events in patients that have had septal myectomy, but those how should I say that? Variable or outcome is a mixed bag of things like atrial fibrillation and strokes and heart failure and so on and so forth. So I have not seen it teased out to the specific of, if you have a myectomy rather than waiting, do you reduce the chance of having AFib relative to somebody else? I don't know I can say that. What I do know surgically is when we have done what is called maze procedures in patients with mitral valve disease and patients who have standalone atrial fibrillation, and you compare the atrial tissue to that of a patient with hypertrophic cardiomyopathy, as David mentioned, there tends to be a lot more fibrosis in the atrial tissue. It tends to be thickened as the ventricle is sometimes impressively thickened. So it's a different disease, the atrial fib, or the substrate for atrial fibrillation in the atrium, the cells themselves are very different than what I see grossly in patients that don't have hypertrophic cardiomyopathy. And I think it makes it much harder to eliminate the atrial fibrillation. It's more resistant to therapy, surgical therapy, at least in my experience.
So somebody asked a question here earlier, and I may not have gone through the full question, but that is, this is a person who had a myectomy in the past and is now dealing with atrial arrhythmias. And they're talking about dealing with those atrial arrhythmias via radiofrequency ablations or cryoablations. That would be the next step. If somebody is in chronic, or if they're having a lot of paroxysmal atrial fibrillation, we can try, but we know that the success rate to atrial arrhythmia ablations in HCM is not quite the same success rate as our non-HCM contemporaries, and that you might have to do more than one attempt, and sometimes 2 and 3, but beyond 3, they don't seem to work at all. But so you get like 40% with the first ablation, and another 40% with the second ablation, and another 20% with the third ablation. But after that, there doesn't seem to be much utilization from the data that I have reviewed. Comments from our faculty? Yes.
Yeah, the challenge of AFib with patients with hypertrophic cardiomyopathy is that a lot of the antiarrhythmic medicines are pro-arrhythmic. So it really limits the toolbox of what the electrophysiologist can use, especially if the patient doesn't have a defibrillator. But the electrophysiologist will usually say that the success of pulmonary vein isolation can be upwards near 90% in some of the patients with lone EF, but they'll tell you probably over 70% in patients with hypertrophic cardiomyopathy. So it's still very good, and especially given that that our options for antiarrhythmic therapy are not very good. We still do quite a lot of them, and they do pretty well.
Absolutely. Okay, a couple more questions. They've come in and they're all nice general questions. So I'm going to keep streaming on Facebook until we start to wind these down. So going back to the individual who was questioning, mavacamten trial versus myectomy, there's an additional question here, and I think we'll just address it as a general anatomy issue. If somebody's coming to you, Nick, and they have an existing right bundle branch block, there's probably a pretty damn good chance they're going to end up with a permanent pacemaker after they meet a surgeon for HCM. Would it be, and this is a Lisa alteration of the question, would it be reasonable, depending upon the age and the level of gradient, to put the pacemaker in first and see if good old-fashioned dual chamber pacing, which only works in a small number of people, might work? Should you try the pacer first if you know you're going to land there anyway? That was a good question.
Yeah, my sense, talking to my cardiology colleagues, is they don't have much, they haven't seen much impact by putting this pacemaker. And I don't know if Craig or David want to answer. If you have a pre-existing right bundle branch, does that make pacing more likely to help with an obstruction? But I don't know. Is it? No?
No, so the audience to understand the background about this, when Dr. Smidir does a myectomy, almost everybody, over 90% of people, get what's called a left bundle branch block. That means the electricity going to the left side of the heart is delayed. And if you start with a right bundle branch block, where there's delay of the electricity getting to the right side of the heart, then it's almost for certain that you will need a pacemaker after a myectomy. Now, the way we've addressed that generally is, you still have to show that that's the case, and so with the myectomy, Nick or the surgeon will put on the epicardial wires, and we'll see what happens after the surgery. But almost everybody will get with a right bundle branch block will require a permanent pacemaker. Now the data on RV pacing and hypertrophic cardiomyopathy, this was lots of studies a long time ago now, and it turns out that for the most part the data was fairly mixed. There are occasionally patients that benefit, but the majority don't, and so we don't put in pacemakers to reduce obstruction Sometimes if patients have a definite indication for a pacemaker, we'll try to pace the right ventricle and see what happens with the obstruction. But in this case, I think usually the approach with somebody with a right bundle branch block would be to do the surgery, put on epicardial pacemaker wires. If we demonstrate complete heart block, the need for permanent pacing, to do it shortly after the surgery.
It was a trick question.
It was.
It was. I just threw it in there. So let's go to the next. Exercise in HCM. How do we adequately exercise and get our heart rates to a good level? Where should the heart rate go? Where should patients with HCM sit in a chair and just get obesity and diabetes?
No. Yeah, exercise is encouraged. So we should not be sedentary, even with HCM. And so, but you do have to keep in mind the limitations, understanding the anatomy that we discussed and the obstruction, the small cavity size. And so you do have to keep in mind that when you exercise, you have to be well hydrated. And then the limits of the exercise and trying to avoid impulse kind of activities, heavy weight lifting. Those are kind of things that are gonna provoke a gradient more likely, and then lead you to have either syncope or passing out spell. And so mostly cardiovascular exercise and light weights recommended. So cardio could be walking, light jog, could be cycling, stationary or regular bike. And you try to work in a sort of a moderate intensity where you're not huffing and puffing, but you still could say some words and be able to speak. And so that's the kind of exercise that will give you adequate cardiovascular health, but not put you in the red zone or in a dangerous heart rate zone where you can have blood flow problems from the.
A very simple way we use to explain this is the talk test. If you can talk while you're exercising, it's probably okay. If you're doing that, I can't talk to you right now because I'm too busy breathing, you probably need to lower the intensity a little bit. So that is my logical diet or exercise comment, and my typical diet comment is if God made it or it grew naturally, it's probably okay to eat. If man messed with it, leave it alone because it's probably bad for you. So if you put the walking and talking and the eating what the earth provided for you, you could probably get a lot fitter than eating packaged foods and trying to be a weekend warrior and pushing it and then finding out that the next couple of days you're going to have really bad HCM days. We don't understand the mechanism completely, but I think there's some muscle memory issue here that you might be able to get through your workout, but 2 days later you find yourself not doing so well. It's a phenomenon that happens. I can't tell you the why, but I can tell you it is a shared experience among your big-hearted friends. So, okay, so somebody who has had a maze. So a maze procedure is for the treatment of atrial fibrillation. It is a surgical procedure. We did not talk about it in detail today, but it's one of the tools in Dr. Smadira's repertoire. So you've had a maze procedure for AFib. You've had no documented AFib for 3, 4, 5 years post-procedure, but you're still on an anticoagulant. Craig, should they stay on an anticoagulant because of the AFib risk, or is this something that they can talk to their healthcare provider about and make an individual choice as to whether or not they can stop their Eliquis?
Yeah, good question. Depends on some of the details here. That the first question is with Nick can speak to this, but with some of the maze procedures, they actually excise the left atrial appendage. Are we still doing that, Nick?
In some cases, or we clip the base of the appendage. But one of the goals of the maze procedure is to eliminate the left atrial appendage as a potential space for clot to form. So if you do a maze procedure, you open the left atrium, you should have completely eliminated the base of the appendage, one way or another, either excising it or clipping it.
Yeah, so if that's the case, then there are certainly times when I would, if we document no AFib, perhaps on event monitors, we know that the appendage has been clipped or excised, then oftentimes we may stop the anticoagulation.
So it's a good
Yeah.
conversation for that person to have.
What's
Right.
that?
It's a
Yeah.
good conversation to have that, can I stop? These are individual choices. This cannot be a blanket statement. Whether the appendage was clipped, how frequent was the AFib? What were the concerns? Is there any other underlying blood clotting disorders? There's so many other things to consider, and that is a good conversation and an appropriate one and a smart one, because we want people on as little medication as possible. And if they can get off, that'd be great. Okay. I am going to stop the streaming at this point. So I'm going to go up here and I'm going to click that. Thank you everybody on Facebook who joined us. We're going to be live on Facebook on Wednesday with Robert Blum from Cytokinetics in a podcast. And we have another Bighearted event coming up with, oh my goodness, who's next? University of San Diego is coming up next. So join us for that on Facebook. And for those who are in the webinar, we're going to continue now. We have stopped streaming on Facebook, and I am going to stop the recording at this time. Stopped recording,